Okay, so moving on to eating and drinking. This is the last of the 6 domains. So eating and drinking is actually a really complex act that we all take for granted, but it actually requires the coordination of about 40 pairs of muscles, and much of the central and peripheral nervous system is actually involved. So obviously with the effects of CJD being quite widespread or very widespread over the central nervous system, those parts of the brain that are involved in bringing food and drink actually to the mouth in the first place, but then the process of chewing, mastication, and then moving the food to the back of the throat and initiating that swallow is a really complex act. In actual fact, the chewing and the movement of food to the back of the throat is actually a conscious act. It's not an automatic reflex. So that's why we find that people can be sort of chewing food for a very long time or holding food in their mouths, we call pouching, which we'll have a look at a little later. Over time, the ability to actually swallow safely becomes impaired. It's called dysphagia, and dysphagia can have a number of very troubling complications, which we'll have a look at in a moment. So really, this is just a table looking at the impact of prion disease on eating and drinking. Now you'll see that so many domains, if you like, of that are controlled and coordinated by the brain are affected by this disease, including memory, cognition, sensory loss, vision, dependence, mood and behavior, and motor function. And each one of those impairments can lead to outcomes such as forgetting if someone's actually eaten and drunk in the first place, actually sequencing the task of not only preparing but also eating a meal. Requires quite a lot of attention and concentration to get right the way through a meal, and you might find that somebody needs increasing sort of supervision and prompting to stay on task and actually get to the end of a meal. And actually, as the disease progresses, actually understanding the meaning of food and drink and actually recognizing it as food or drink in front of them can become impaired. Now, overeating can be a problem. Eating non-foodstuffs as well can, in some people, become a problem. So requires a lot of supervision. Over chewing, pocketing or pouching food, spitting, and having that sort of oral control of the coordination as food is manipulated within the mouth. Having this sort of spatial awareness to actually get food from the plate to the mouth can be challenging. Using cutlery and drinking vessels can become increasingly difficult. Actually, mood and behavior has a part to play here as well. Sometimes people can become suspicious of food and may think that it's been poisoned, and they might feel that the way that they're feeling is as a result of having eaten poisoned food and things, and can become quite anxious around food as a result. Food preferences can also change. People can start erring towards sweeter foods quite commonly, and that's looked at as part of the diagnostic workup for this disease. And actually having the motor function, so actually being able to bring about purposeful and coordinated movements can affect someone's ability to eat. Myclonus, as Margaret was saying, can make it really, really difficult to actually get food to the mouth. And actually, the consequences of this can lead to a compromised airway, and we'll look at what the possible consequences of that can be in a moment. So these are some of the signs of dysphagia. Sorry. Things to look out for in your loved one, that their swallow might be starting to become impaired. It's really important to keep an eye out for these things, such as coughing and spluttering whilst eating and drinking, having a sort of wet voice, or difficulty clearing one's throat, or sort of wheezing after eating, having difficulty chewing and swallowing it, just taking much longer, drooling and salivating more, and not being able to manage one's saliva in the mouth, frequent throat clearing, perhaps regurgitation of small or large amounts of food, and actually being left with food residue in the mouth after a meal. And some of the consequences of this dysphagia, or the impaired swallow, are that some people can start losing weight, can become dehydrated, can suffer malnutrition. These can all have knock-on impacts on somebody's performance and overall health. Poor oral health, obviously, if food is left in the mouth after a meal, it can have negative impacts on people's teeth and gums and things. And respiratory problems, and this really is the most dangerous aspect, if you like, of dysphagia, is aspiration pneumonia, which is where food and fluids can end up going into the lungs, sort of down the wrong tube, so to speak, and that can have very serious consequences in terms of infection, and if left untreated, can actually go on to become a cause of death in some of our patients. So it's important to look at how we can manage dysphagia, and really it is a multidisciplinary team approach. So what we'd be looking to do is make sure that these various people are involved in looking after your loved ones. So there's the speech and language therapist, and they can look at sort of modifying the texture of the food and fluids. So foods will become progressively more pureed to make them easier to swallow, less liable to be choked on, and fluids will become progressively thicker through the use of thickening agents, so that it's easier for the swallow reflex to kick in and bring that hydration to the stomach rather than it slipping into the lungs. The occupational therapist can look at any changes to the environment, and also any kind of tools and utensils that can be changed, maybe through the use of kind of sippy cups or large handled cutlery and various other sort of adaptations that can make meal times a bit safer for people. And a dietitian may need to become involved as well. Sometimes if people's eating and drinking has tailed off, then they can look at providing supplements, so manage that risk of malnutrition. And they also manage artificial nutrition and hydration if a person goes on to have nasogastric or a rig inserted, and we'll have a look at that in just a moment. So here's some tips for feeding for carers that can be really, really useful to reduce the risk of dysphagia and to promote a sort of successful mealtime. So sitting somebody upright to allow gravity to bring the food into the stomach as opposed to going into the lungs and things. Reducing distractions, so maybe turning off the TV, closing the windows if it's noisy outside. Just get somebody to sort of concentrate as much as possible on the task in hand. Don't rush, which I think is a bit of a theme of this evening's presentation. Using small mouthfuls and trying to have a sip of drink between mouthfuls to help to clear the mouth. Eating little and often can sometimes be useful, as opposed to having a huge meal put down in front of you. It can be useful to sort of break that up. Contrasting tastes and temperatures can promote a safe swallow as well. So particularly tasty things, sort of fruits and curries and things, and it's things that elicit a sensory response, so that the person sort of knows that they've actually got food in their mouth, and they can sort of manipulate it appropriately. And also temperatures. So you'll often find that something that's particularly cold, maybe ice cream, will elicit a good strong swallow as well, and also things that are hot, but obviously within safe limits on the hot things, to avoid a burnt mouth. Now, checking the mouth is clear once the food has been finished is useful as well. Again, you don't want that food residue to stick around and breed bacteria that can be bad for your oral hygiene. So thinking about your twice daily mouth care and making sure that all parts of the mouth are included in that. So not just the teeth, but the tongue and palate can also be cleaned to make sure that's all nice and clear. I did want to mention artificial feeding. This is obviously the delivery of nutrition and hydration by way of artificial means, typically a nasogastric tube or radiologically inserted gastronomy, otherwise known as a rig. Now, my colleague Kirsty McNiven, who's a clinical research nurse, who I need to thank for helping putting together these slides on eating and drinking this evening. She's very much a kind of specialist in our team when it comes to eating and drinking, having been the lead author on a paper on artificial feeding in patients with the advanced stages of prion disease that was published in Brain Communications a couple of years ago. She actually carried out this study that was published, and what she found was that artificial feeding did indeed prolong the life in the advanced stages of the disease. So typically in the kind of akinetic mute, so non-moving, non-communicating advanced stages, as it says, of the illness. But she also found was that it didn't really contribute to somebody's quality of life. So if you like, their life was prolonged in this very advanced stage, but she also found that it came with significant risks and disruption to somebody's routine and things, and it can involve a number of hospital admissions, comes with the risk of infections and other things that can lead to undesirable consequences that can be avoided. And as a result of this, we don't routinely recommend artificial feeding in people with CJD. In fact, very, very rarely. Think that it's probably not in somebody's best interests to undergo the possible side effects associated with artificial feeding to prolong that advanced stage of the disease. And what we do tend to recommend at that stage is that we adopt a risk or comfort feeding approach, which is where we're still attempting to provide a nutrition and hydration orally in smaller amounts, in the knowledge that somebody's swallow may be impaired, and so there is a risk of aspirated pneumonia. But while someone is able to take some food and drink, then yeah, that is the preferred approach at that stage.